So this is Mrs. Wentworth, Ms2 Ch, Chapter 8. This lecture is about care of patients with cancer. And I am going to skip through the objectives and go over to slide 5. So first off, before we even start, in the United States, the most type of new cases we have every year. For males, it's prostate cancer, and for females, it's breast cancer. However, the leading cause of death by cancer in the United States for both males and females is lung and bronchus cancer. All right, now cancer is defined as a group of diseases that grow in an uncontrolled manner with the spread of abnormal cells. And if all cancers that were detectable were diagnosed in the early stages before they spread, the survival rate would be 95%. Okay. Since 1977, there really hasn't been a big change in the number of cancer cases per year, except for maybe a slight decrease in lung cancer. And a lot of this has to do with education about cigarette smoking. Unfortunately, about 1,000 children begin smoking every day. It's still a problem. Malignancy or cancer can take a big toll on the body. I found this interesting. So because these cancer cells divide so rapidly and constantly and go, divide all the time, patients have a big, huge increase in their nutritional needs when they have cancer. And this is why a lot of times we see patients with cancer present to us and saying, I've lost 20 pounds in the past 2 months. And, you know, this isn't just GI cancers, but cancer anywhere in the body. There's such a fast rate of cell division that the metabolic rate goes up and the body's nutritional needs go up. Now, when we talk about cancer, we talk about neoplasms. Neoplasms are basically abnormal replication, meaning cell division replicating itself, abnormal replication of cells that results in the new growth of a tissue or a tumor that is not beneficial to the body. Now, a benign neoplasm is usually harmless, and it's usually what we call encapsulated, meaning it has a fibrous closure around it that keeps it in one place. The cells don't get out and go through the body. A malignant neoplasm is where we see uncontrolled growth of cells, and these cells can cause a tumor that can actually lead to death. And then there's the term metastasis, and metastasis means movement of the abnormal cells from the site of origin. So we have an abnormal replication of cells. So we have just, let's say, one little abnormal cell, but then it replicates, and it replicates, and it replicates. And all those cells that it replicated into, they replicate, till all of a sudden this one little cell now has a huge amount of cells that are abnormal around it. And as these cells, as there's more and more of them produced, they start to bond together and cause a tumor. Now, when we talk about a benign neoplasm, this is usually harmless. Okay, so these are abnormal cells that have divided and caused a tumor, but it's benign. And it's harmless. The big thing to know about these benign tumors is that they are encapsulated by a fibrous capsule, and they will not spread to the surrounding tissue. The capsule prevents the release of cells, restricts their spread to other parts of the body. But benign tumors, although they aren't malignant and they're not going to spread, they can cause a problem if they press against any organ, interfere with the normal structure and function of nearby organs. Now, a malignant neoplasm has a cell that has a change in its DNA makeup and function. These do not look or behave like normal cells. The nuclei of these cells are large and irregular. They fail to follow the rules that regulate the reproduction of normal cells. They don't seem to know when it's time to stop multiplying. And the offspring of cancerous cells proliferate or replicate or multiply in great numbers. And these can destroy surrounding tissue while spreading to distant parts of the body. This, if you were to look at the DNA in these cells, the DNA is altered, the replication is disorganized, they can invade nearby organs and travel throughout the body. They grow increasingly disorganized and often form tumor masses. Some cancer cells actually take on characteristics that are new, and they do not in any way resemble the cells of the original tissue. These malignant cells can invade neighboring tissues and travel to other parts of the body, and there they establish another colony of malignant cells. The demand for nutrients depletes the supply of nourishment available for normal cells. So that's where I said, they have such a high, they increase the demand for nutrients so much that the person will start to lose weight. And here's a little visual, okay? So we have nice uniform cells that have replicated hanging out here, and these are normal. And then down here, we have cells that are just all kind of looking different and all over the place in different orders, and it's kind of like it's the wild, wild west. Now, classifying tumors. So they are classified according to the substances that they are formed from. Okay. OMA. OMA means swelling, whether it's malignant or not. So think about if you get a really big bruise from bleeding, it's known as a hematoma. Okay, so the OMA is in there. It doesn't have to be malignant. It just means there's swelling. Now, sarcoma, sarc usually refers to the bones, and oma means swelling. And these are tumors of the bone, the muscle, and connective tissue. And then there's carcinoma. Now, carcinoma, these come from our epithelial in origin. And this is usually skin, mucus, membranes, and you also find epithelial cells in the stomach, the uterus, the lung, the skin, the tongue. All right, so some of the terms that we hear are carcinoma, lymphoma, sarcoma. These are all malignant. These are all cancerous. Okay, leukemia, leukemia and lymphoma. These are cancers of the blood. Melanoma, well, melanin is the pigment of your skin. Melanoma is a skin cancer. And we talk about metastasis. Now, metastasis is the movement of cancer cells from their original cancer site to other parts of the body. Once this happens, the cancer is no longer localized. Now, not all malignant cells will metastasize, but the great majority of them do. So, here's a picture of how we manage to disseminate or distribute or spread cancer. Okay. First, there can be direct extension into the neighboring tissue. There can be permeation along the lymphatic vessels. Embolism via lymphatic vessels to the lymph nodes. And these malignant cells can also invade a body cavity by using diffusion. So these malignant cells actually travel in blood and body fluids. Now, interestingly enough, they can be transplanted from one organ to another by gloves or surgical instruments. And then once they enter a body cavity, they come in contact with another organ, and the malignant cells will leave the diseased organ into the abdominal cavity and attach to the mesentery that's there. Now, the prognosis is going to depend on how much the malignant cells have attacked body tissues. So we talk about cancer that is in situ. And this is a localized growth that remains at the original site. It has not yet released its cells, even though the growth may have invaded underlying tissues, but these cells are not out and about. And another way of saying this is localized. So all the malignant cells are in the area where the new growth started. And at this stage, cancer is much more easily destroyed. And then we talk about regional malignancy. And this is cells from the original malignancy have spread from the body area right around the tumor to the nearby lymph nodes. The spread has been limited by the body's protective mechanisms, but cells continue to grow and multiply. If a regional cancer is not successfully treated, malignant cells will eventually break away from the region and spread throughout the body. Now we have the TNM staging system. So when we do this, the T is in reference to the primary tumor. The N tells us the status of the regional nodes, and the M stands for the presence of metastasis. And the number that's written beside each letter indicates how much malignancy has spread or attacked other tissues. So we talk about the T, primary tumor. T1 is a small tumor. T2 is a medium-sized tumor. T3, it's a bigger tumor, and T4 is a very large tumor. So if we had, and then again, the N refers to the regional nodes, the M refers to metastasis. So if we look at this tumor that we're told is a T1 NOMO, well, T1 tells us it's a small tumor. N for the nodes, and O means nothing has, the nodes are not involved, and MO means it has not metastasized. So we went over the levels for the T, but the levels for the N. So 0 level with the N means no nodes nearby are affected. The tumor is totally just within itself. If a tumor is given a rating of N1, then we know that the closest nodes to the tumor are affected. If it's given a rating of N2, then spreading is moderate going towards extensive. And a tumor that is N3 is widespread. The M is a little bit easier. There's no Mets as MO, or M1, there is Mets. So if you have a tumor, let's do this one again, T1NOMO. So the T1 means it's a small tumor. The NO means none of the nodes around it are affected. And the MO means there's no metastasis. Now we can look at the next example in the PowerPoint, and it's T1, N2, M3. All right, so you have to break this down. T1 means it's a small tumor. N2 means that there's moderate regional involvement, moderate spreading. And M1, again with metastasis, it's either a 0 or a 1. So this means metastasis has happened. All right, so I'm going to give you one more that's not on the PowerPoint. T3, N2, M2. This would be a large tumor, okay, with extensive spreading, and yes, Mets. All right, I might have said that wrong. It's T3, N2, M1. Excuse me. Okay? Causative factors. So all cancer results from defects in the DNA of genes. And this can be inherited or caused by a mutation somewhere. We have things called oncogenes, and then there's tumor suppressor genes, which we will talk about them in a little bit. And then we talk about immunocompetence. And immunocompetence is just referring to how well the immune system works. And then the other causative factors are carcinogens in the internal and external environment, which again we're going to go through in the next couple pages. Now we talk about mutation, and this is the change in the DNA sequence of a gene, and it is permanent. So you have a piece of DNA here, and it's in its cell, and it's happy as can be and non-mutated. Something happens, so now the cell has mutations, and it's shown by the one line being red, the line here being red, and this is a mutated cell. And these mutated cells can get together and form a tumor. And then we have oncogenes. So oncogenes are cancer-causing genes. And here there's mistakes in the instructions inside a cell's DNA genetic code. So newly created cells are no longer normal. Okay, and the defective gene tells the new cells to multiply at a higher rate and to keep multiplying defectively. Defective coding prevents the newly created defective cells from dying and being reabsorbed. So now there's more and more of these. And this can result in a tumor or a mass. And this is kind of where cancer research is headed right now. We're looking at these oncogenes and finding that there may be some very promising treatments for cancer coming out of these studies, of these discoveries. Now we have tumor suppressor genes. These are healthy, normal genes that control the growth of cell in the bodies. Okay? And these healthy, normal genes affect the body's ability to withstand exposure to carcinogens. So what the tumor suppressor genes do is they're kind of like there's a stopgate to prevent the mutation in the DNA from happening. And then immunocompetence. This just refers to the capability of the immune system to deal with foreign cells, whether they're bacterial, whether they're viral, or whether they're malignant. But keep in mind that immunocompetence, along with everything else that's good about your body, decreases with age. So therefore, in the single biggest risk factor for developing cancer is age. Now, chemical carcinogens. These are cancer-causing substances, and they're found very often in the external environment. And these are chemicals, radiation, viruses. The first carcinogen was actually identified, or that was identified. There was a high incidence of cancer of the scrotum. And this was noted in chimney sweeps in 1775. Now, I'm not quite sure what they were cleaning those chimneys with. Hopefully it was a broom. But all these gentlemen were showing up with cancer of the scrotum. And this is the first time we were able to put together some sort of an exposure to a chemical to a group of people having a high incidence of cancer. Sometimes there can be carcinogens in the internal environment. And that can be hormones, inherited genes, or advanced age. Now, it's surprising to see that viruses is under here from the external environment, but there are actually a lot of viruses that put you at a higher risk for developing cancer. And things like hepatitis B and C, patients here are more susceptible to liver cancer. HPV, patients who have HPV are more susceptible to cervical cancer. Kaposi sarcoma, Patients with HIV develop Kaposi sarcoma. And then Burkill lymphoma is a lymphoma that's often found after someone has the Epstein-Barr virus. Not often, I mean sometimes there's an association. Not if you have Epstein-Barr, you're going to get cancer. That's not what I meant to say. All right, occupational carcinogens brings it to mind again, those poor chimney sweeps that hopefully had a broom. There's petrofluorocarbons, and these are PCBs, polychlorinated biphenyls. Some pesticides, like pesticides with DDT. Pitch or asphalt or crude paraffin, petroleum products. And of course, irritating substances in the air. People who work with, there's a lot of secondhand smoke, asbestos, chemical wastes from industry and automobiles. So all of these are occupational carcinogens that are often found in the workplace. And the longer you're exposed to these, the chances you have of developing cancer. So all those guys who were dedicated to their job and stayed there forever, not so good. All right. And here's a couple. Again, soot. We keep going back to these poor guys. Let them just have a broom and rest in peace. Soot, aniline dyes, vinyl chloride, nickel, arsenic, chromate, benzene. And if you are interested in this, on page 148, there is a table that goes ahead and lists all the different carcinogenic substances that are often found to be occupational related or virus related. Okay. All right. So cigarette smoking. Linked to cancer of the lung. And remember, that's the leading the cause of cancer deaths in the United States. But it's also linked to esophageal cancer, pancreatic cancer, bladder cancer, and kidney cancers. All right, so of course we're going to encourage those who smoke to quit. 90% of lung cancers in men and 79% in women are related to smoking. And use of tobacco, along with heavy intake of alcohol, is related to several kinds of cancer. Okay? Cigarette smoking has also been linked lately to liver cancer and colon cancer. Now, we have something called promoters. So promoters aren't carcinogenic when they're found by themselves. But when they're in the body with a known carcinogen, cancer occurs faster, okay? Unfortunately for a lot of people, alcohol is a promoter. And I always remember that, like alcohol being given away at concerts. Well, I guess they don't do that anymore. They did years ago. As a promotion. So alcohol is a promoter. Because when nicotine is present, cancers occur at a faster rate on those that also consume alcohol, heavy consumption of alcohol. As opposed to someone who uses nicotine but does not drink alcohol. So alcohol is thought to be the promoter in this situation. And about 90% of all head and neck cancers are tobacco plus alcohol related. So we're talking about cancer that alcohol alone doesn't cause. But if someone is smoking using nicotine and then they put alcohol on top of it, that makes the cancer occur faster or more likely that it's going to occur. And these are known as promoters, like promoting alcohol at a concert. Now there's also another promoter, is chronic irritation. So this would be somebody with Crohn's disease. Patients who have Crohn's disease, which I don't remember if we've gone over that. Yeah, we did in Med-Surg 1. Crohn's disease, these patients, have a high risk of colorectal cancer. Okay? And then when we talk about, so that's what we're talking about with chronic irritation, because their bowel is chronically irritated. And a lot of times they end up with colorectal cancer. Presence of a mole or exposure to chemical carcinogens can be an irritation promoter. So there are immunosuppressive drugs that are used to suppress organ transplant rejection. And that's great. You get your organ, and now you just try not to reject it, and then they can be associated with non-Hodgkin's lymphoma. Doesn't always happen. There's an association. Synthetic estrogens are linked to a higher incidence of endometrial cancer. Many of the drugs used to treat cancer affect the immune system and can predispose to other types of cancer. Patients who undergo treatment for breast cancer often many years later develop leukemia. So this can be a cancer that arises from drug therapies. And then there's physical carcinogens, X-ray machines. Now, ironically, people that get a lot of exposure from X-ray machines, for instance, someone who's an X-ray tech, you know how they wear badges that keeps track every month of how much radiation they're actually exposed to. Well, patients that come in with a higher level of radiation are very often prone to leukemia. So X-ray techs, very prone to leukemia. Patients that are exposed to radioactive elements or UV rays from the sun, all of these are carcinogens. And these are capable of penetrating certain body tissues and cause the development of malignant cells in the affected area. People with fair complexions have less protective pigment, so the whiter your skin is, and therefore are more likely to develop skin cancer from UV radiation than are people with dark skin. Of course, everybody should avoid the sun to a degree, but patients who have very pale skin. So if you have somebody who's very pale that says, you know, I'm getting married in a month and I want to have a nice tan and I'm going to go ahead and expose myself, probably the best option that you can offer them is not a tanning booth. Tanning booths are even probably worse than the sun, but spray tans. You just have to find one that is not orange. Just my own 2 thoughts there. There's continued concern about the dangers of excessive radiation in the environment, especially long-term effects that are not right away apparent, but eventually can be related to malignancy. In addition to leukemia, patients can develop cancers of the skin, of the bone marrow, the breast, the lung, and the thyroid. And these are all thought to be linked to exposure to radiation. And then there's Hiroshima. Remember the atomic bomb dropped in Hiroshima, and it was found years later on a high incidence of leukemia in people who were present. Radon gas. People who live in areas that have more radon emission from the earth have a higher incidence of malignancy in the population than people in areas that are low in radon. I know a lot of times if people are buying a house, they'll do a radon test just to make sure it's not in an area with excessive radon. And then there's viruses. I went through, and these are known as oncoviruses because they can cause cancer. And I just talked about those a couple slides back. There was Kaposi sarcoma, HPV, hepatitis B and C, Burkitt's lymphoma from Epstein-Barr, and these are known as oncoviruses because they can cause cancer. They're capable of introducing new genetic material into a cell, and that can cause the transformation of a healthy cell into a malignant one. Cell reproduction can be altered when viruses interact with carcinogens. And viruses such as the HPV can damage the immune system, decrease the immunocompetence, and that causes the body to become more susceptible to the growth of abnormal cells. The hepatitis B virus is carcinogenic for liver cancer, as is the hep C. Epstein-Barr with Burkitt's lymphoma. Cases of adult T-cell leukemia and lymphoma are caused by human T-cell lymphotropic virus. And several types of HPV cause cervical cancer and are related to throat and mouth cancer of non-smokers. So now we talk about genetic disposition. And actually, this has become a strong enough theory that current cancer research really is looking at finding and identifying gene markers in patients with cancer. So research is revealing there's a genetic predisposition to various types of cancer. Breast cancer is more likely to occur in women who have a close female relative who developed breast cancer before the age of 50. Gene markers have been found for colon cancer, breast cancer, prostate cancer, pancreatic cancer, as well as leukemia. However, only 5 to 10% of cancers are related to a directly inherited gene. We talk about BRCA1 and 2 for breast cancer. The remaining cancers are caused by genes that are damaged throughout the lifetime and not inherited. And some people are just more susceptible to these mutations. Some populations are at a higher risk for certain types of cancer. Of the 4 types of melanoma, African Americans are most susceptible to the acral lentiginous type, and whites are least susceptible to it. Lentigo maligna melanoma is most often found in Hawaii. So current research is focused on finding genetic markers or oncogenes. Such markers, or the proteins that they actually produce, can identify high-risk individuals who might undergo more vigorous, regular diagnostic testing to detect any malignancy at their early ages. For instance, again, the BRCA1, BRCA2 genes. Someone who is positive for these genes would have significant more mammograms, MRIs, etc., than someone who wasn't. So here's some intrinsic factors that just, these are factors that are from within and relate to increased risk. Your age. There's an increased risk of cancer as you age. Gender, especially for different types of cancers, and your race. Stress. So considerable stress over a long period of time affects the immune system, and this makes your body, your immune system not as effective, and as we have seen, that increases your risk of cancer. Diet and alcohol we're going to go into. And exposure to different carcinogens, whether it's occupational, environmental. So, diet and nutrition. We have to encourage the maintenance of normal weight because obesity is considered a risk factor for many types of cancer. And it also makes early detection of many cancers difficult. So again, keep looking for that great weight. Nitrite and nitrite food additives are also known to be cancer stimulators, which means they encourage cancer. Unfortunately, for many of us, that includes hot dogs. And fun fact from Mrs. Wentworth, charcoal broiled foods can be considered a carcinogen. So if you like your hot dog really, really charcoal broiled, it's probably not something you should eat every day. Groundwater is often contaminated with fertilizer and pesticides, so if you have a well, that's something to think about. And citrus fruit, interestingly enough, citrus fruit that has vitamin C can decrease the chance of nitrites hurting a person. So everybody should be encouraged to eat a variety of citrus fruits. They actually have some anti-cancer benefits. Moderation in the drinking of alcohol is recommended because alcohol consumption alone has been shown to increase several cancers, let alone be a promoter. Excessive alcohol consumption can lead to liver damage and possibly liver cancer. So, warning signs of cancer. Well, there's unusual bleeding or discharge, a sore that does not heal, a change in bowel or bladder habits, a lump in the breast or actually anywhere in the body, a nagging cough, an obvious change in a mole, and difficulty swallowing. And as always, let's keep our older patients in mind. So, older patients are at an increasingly higher risk for developing cancer. Their immune systems are not as efficient as that of a young person, and many cancer screening programs we have now found need to begin at age 40 to 50 years. Now, there's many diagnostic tests that can be done to diagnose cancer. I guess that's what you would do with a diagnostic test. And they can include biopsies, and that would be taking a piece of tissue or tumor and sending it to the lab. Radiologic studies, I mean, there's probably about 1 million different ones. Endoscopy or colonoscopy. Over the age of 50, it's recommended to have a colonoscopy yearly. An endoscopy is when the endoscope is taken and passed down the esophagus and into the stomach. And then there's laboratory tests that can be done. So we're going to talk about the biopsy. Now, the biopsy is removal of the lining, of living cells for the purpose of looking at them under the microscope. And we can get to these cells many ways. There's surgical excision, which means just cutting it out. There's aspiration, if we can go in with an aspirator and suck some cells out of the tumor. Frozen section, a piece of the tumor is sliced and put under a microscope. Fine needle aspiration, where a needle is put into the tumor. And then there's percutaneous, and this is just going through the skin to a tumor. Now, mammography under radiological studies. So mammography, we have found that routine mammograms decrease mortality rates 20 to 30%. At age 40, it is now recommended that women have a yearly mammogram. All right. And personal story from Mrs. Wentworth. I was 42 and I went for one of those yearly mammograms and was in the OR 4 days later having my tumor removed and then started chemotherapy. So really, they're not a bad thing to actually pay attention to the fact that they're recommended yearly now for women as soon as they turn 40. Radionuclide or isotope, and this is just another radiological study. If you look and you inject a tumor, a cold spot means a tumor does not accept the isotope, and a hot spot where there is cancer would tell you that that tumor is probably malignant. So if you inject an isotope and you watch it under X-ray go towards the tumor, if the tumor takes it, it's probably malignant. And CAT scan. This is non-invasive, and it can at least tell us the size, the shape, the contour, and the density of an organ, and let us know if we see anything that's out of normal there, like a tumor on the organ. MRI, magnetic resonance imaging, and this actually slices of tissue. This lets us look at the tissue, one little piece at a time, and it can sometimes see tumors that CAT scan would miss. But always remember, anybody with a pacemaker or any part of metal in their body cannot have an MRI because of the powerful magnets that can bend and twist metal and damage the body. We talk about lab tests. Well, a CBC, that's going to tell us if there's a normal amount of white blood cells, red blood cells. Is there a blood cancer going on? prostate-specific antigen, or PSA. So this is a blood test that can tell us if a man is at risk for, or if a man, often if prostate cancer is present. Current recommendations are that men have it drawn past the age of 50, and then gets repeated at various intervals depending on the patient's risk factors. But here's something that doesn't always get followed. If your patient has a UTI, they cannot have their PSI drawn at that point because they will get a false positive, okay? So with the PSI test, if there's a UTI present, it doesn't get drawn. Now there's also tumor markers. There's the CA-125, and this can sometimes detect the presence of ovarian cancer or its recurrence after therapy, okay? And all these tumor markers detect biochemical substances that are released into the cell by tumor cells. They are not 100% accurate for diagnosing tumors. They can help to confirm a diagnosis, and they can help to determine a response to therapy and detect recurrence. So for instance, the CA-125 is used to detect the presence of ovarian cancer or its occurrence after therapy. So a lot of times people who have ovarian cancer that is successfully treated would have CA-125 levels drawn periodically to make sure that the cancer isn't secretly coming back. And then there's the CEA, or the CA-19-9, and these can detect the recurrence of gastrointestinal, pancreatic, or liver cancer after the initial treatment. And the CA-27-29 is used most frequently to follow the progress in breast cancer treatment, and then later on to check for recurrence. Now, assessments or data collection for these patients. We want to look at the physiological effects of the disease. Patients' knowledge and understanding. You know, a lot of times it's hard to teach patients when they first have this diagnosis because they're so flippin' overwhelmed. Their whole life is just turned upside down. It's when the patient is able to start and ask questions about the disease process or the treatment process. Now we know they've accepted it and they're ready for more teaching. We have to include the psychosocial needs of the patient and the family, anticipate the therapeutic effect of various treatment modalities, and prepare the patient for lifestyle changes and sometimes the anticipation of death. Things that we want to keep in mind when caring for a patient with cancer: we want them to remain free from infection, or if they have a cancer of the blood, free from hemorrhage. A lot of patients are nauseous. We want them to be able to eat. We want to maintain their weight. And a lot of times patients have to have part of their body removed. We want them to report that they're adjusting to their new body image. And these patients, we have to get them to verbalize their fears.